Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Regeneron Pharmaceuticals, Inc. and Sanofi.
Hi, I'm Dr. Jonathan Gaffin, pulmonologist at Boston Children's Hospital and Associate Professor of Pediatrics at Harvard Medical School in Boston, Massachusetts. Welcome to this program entitled Beyond the Flare, Rethinking Steroid Use and Disease Trajectory in Pediatric Asthma. Joining me today is Dr. Leonard Beccaria, Professor of Pediatrics at Monroe Carroll Jr. Children's Hospital at Vanderbilt University in Nashville, Tennessee. Before we begin, I'd like for you to consider this question as we go through the discussion. How many flares or steroid bursts in a year feels like too many for a child? And do you act consistently when that threshold is crossed? For decades, corticosteroids have been a mainstay for managing asthma. However, growing evidence highlights not only the acute, but also the cumulative risks of repeated oral corticosteroid use in both adults and children. So Len, what do we know about oral corticosteroid use in children with asthma and the impact it can have on them, both in the long term and in the short term?
Yeah, so we've been using systemic corticosteroids as rescue therapy in acute asthma flares for decades. And for the longest time, it was really felt that these short, infrequent bursts were actually relatively harmless. They helped resolve the episode, and it wasn't clear that they had cumulative long term concerns. However, recent evidence really does highlight that the cumulative exposure, even through childhood, especially during this period of vulnerable lung and skeletal development, may have greater impact than previously recognized. We know that exacerbation rates are highest in children, and therefore their risk of having multiple courses of systemic steroids go up. And we know that the risks really fall into three sort of windows. The immediate short-term risks, which I think everybody recognizes, behavioral changes, sleep disturbance, appetite augmentation. Those were all felt to be relatively manageable. There are more medium-term risks, including persistence of weight gain, and then long-term risks, such as impairment of bone growth, bone health, bone density, and recent studies highlighting the augmented risk of cardiovascular disease, cerebrovascular disease, diabetes, hypertension, and bone loss. And these really can occur after several courses per year, and many children get multiple courses year on year. So it's really not hard to see how these risks accumulate.
And what about inhaled corticosteroids? Any concerns about long-term or high-dose use of inhaled steroids?
So inhaled corticosteroids are and will continue to remain the cornerstone of asthma management. At low to medium doses, their safety record is really quite good and quite reassuring. As we get to higher doses, these have not been as well explored in clinical trials, so we really don't know the long-term effects of high-dose, long-term exposure of inhaled corticosteroids. Furthermore, children who are receiving those therapies and continue to experience exacerbations also have the added exposure of repeat courses of systemic steroids, thereby even further augmenting the cumulative corticosteroid burden and risk. So, John, as we think about these risks and keep them in mind, let's suppose that a child comes to your clinic after having received a second course of systemic steroids for an asthma flare this year, but otherwise appears to be well controlled in between these episodes. How do you view these exacerbations and oral corticosteroid use? Is this a signal to you that this is uncontrolled asthma? And what do you do as you think through the next steps in asthma management for a patient like this?
I think that's a really good question because it is a very common scenario. And in fact, the majority of kids, as you mentioned, can have their asthma fairly well controlled from a symptomatic basis, um, just with regular inhaled corticosteroid use and more routine asthma management in between exacerbations. But having repeated exacerbations in and of itself is really a sign that more needs to be done. Uh, there each sequential exacerbation has its own morbidity. A child misses school. The family is having difficulty at home and can really be disruptive to everybody's schedule. And the steroid course itself could lead to all the side effects and long-term risks that you mentioned. So I really do think that individual steroid courses in and of themselves are a harbinger of, not just loss of current control, but a good predictor of further loss of control in the future. And we know that from several studies that have shown that even just a single exacerbation is the best predictor for an upcoming exacerbation within the next 12 months. The other things that I really want to focus on are risk of the steroid side effects with the family that you had mentioned, and then more and more research showing that these recurrent exacerbations of asthma are in and of themselves a risk for long-term abnormal lung function or decrease in lung function as kids get older and grow into adulthood. And that's a real risk that's not present in the clinic at the moment, but something that we really want families and pediatricians and the healthcare community to be aware of, as this really sets the person up, the child up for what could potentially be a long-term morbidity from uncontrolled asthma. So when the child comes into the office, we really want to focus on a few different things. Considering that even a single dose of a systemic steroid is a great time to intervene and start to address things that might be modifiable in how they're getting their medications. Is their adherence good? Are they taking the medications the correct way? And frequently, we'll find that people aren't using their spacer chambers, which is the best way of delivering the inhaled steroid, or other variations in technique that just make it so the medication's not getting to the child the way that we need it to. We want to assess environmental triggers that may be contributing to some of that loss of control, comorbidities that the child has that if we could improve on those would make their asthma management much easier and prevent further exacerbations. And then, of course, evaluating for other social determinants of health that place that child in a high risk category for having future exacerbation and intervening wherever we can.
Yeah, I think those are all really essential points. And, it was, I get reminded of this all the time in clinic that we always need to go back to basics when we talk to our patients about asthma management because almost any point along the asthma management path, a problem can arise. I saw a child just a couple of weeks ago who was taking their controller inhaled corticosteroid twice a day, every day. But when I asked how long an inhaler of inhaled steroid lasted, they said about 6 weeks. And I said, but if you're taking it twice a day, we know that that only has 4 weeks worth of medicine in it. And they said, well, I keep using it until it's completely empty. And they were unaware of the mismatch between inhaled corticosteroid doses and the amount of propellant in the inhaler. And just by or helping them understand that when the counter reads 0, they're out of medicine and need a new inhaler, may have been enough to get them back toward control rather than escalating their care. So I leave no stone unturned. I think even the simplest parts of asthma management need to be reviewed because there are families out there who may be encountering one or more of these.
And so we've talked a little bit about the exacerbations and some of these other risks to the child. What are some additional red flags that prompt you to reassess a child's asthma management?
Yeah, so asthma that's uncontrolled can show itself really in one of two domains. It can show it as a day to day symptom burden, or it can show it as exacerbation and exacerbation risk. And I think all of these are equally important red flags because in any given child, they may have one or the other that dominate their clinical picture. So children who are needing rescue inhaler more frequently than usual, children who are waking up at night needing rescue treatment. Children who have experienced more than a single exacerbation in a year to me is a red flag. And truthfully, even one exacerbation is a red flag because, as you mentioned, that single exacerbation is also often followed by a second, and we really need to take those seriously. So, John, given how care can be fragmented and patients seek care in multiple locations, what are some ways you found to be able to effectively track cumulative corticosteroid exposure in children in your practice?
I'll admit this is really challenging, and especially in this day and age where a single dose of dexamethasone given in an urgent care setting or an emergency department that may not be your own is really hard to track down. Uh, if longer courses are given, then you can sometimes track pharmacy data to see that a child was prescribed a course of prednisolone, but it can be very challenging. I think there's a few different methods, and none of them are perfect, that can really be helpful. One is for general pediatricians, really keeping an eye out for any of the urgent care or emergency departments and notes that come your way and flagging those kids to make sure that they come in immediately for a reevaluation, not just of the acute exacerbation, but also to make a good plan to prevent the next one. Um, in some electronic health records, there's the ability to create registries, like high risk registries. And I've seen this work really well in some general pediatric practices where once they get that first indication that either the child has had a course of systemic steroids for an asthma exacerbation or some of the other risks that you mentioned that would place them at high risk for exacerbation, they can flag that child and then have a roster of kids that they periodically check in on every few months, either by personal outreach or again, looking through the electronic records to see have they been seen in an urgent care or an emergency room. And I think that's been highly effective, but nothing perfect right now to really be able to capture all this data.
Yeah, I'd support that. The other point that I've really begun implementing is not having families have stockpiles of systemic steroid available at home for use as they think is necessary, and no more than a single dose available at home without seeking healthcare advice.
I think that's really important. I would also just add, part of this is educating families on the risks and making sure that they know, even if they seek care at a facility that's not your own, that they need to be reporting that back to you so that you can keep track and intervene appropriately.
Exactly. So going back to the case, families often view systemic steroids as a very important and highly sufficient way to control asthma. Asthma gets uncontrolled, they get a course of systemic steroids, and in a couple of days, they're much better. How do you typically approach these conversations with parents about the risks of oral corticosteroids?
Yeah, it's a little tricky. I think we certainly don't want parents to start not getting systemic steroids in a situation that really requires it. But we want to make sure that everyone's educated that that event itself is a sign that the asthma is not well controlled, no matter how well controlled you thought it was leading into the event. I think typically these conversations with parents, they just focus on sometimes showing them the difference between the strength of the inhaled corticosteroid dose that they're getting on a routine basis that might prevent the exacerbation compared with the slug of high dose systemic corticosteroid and the different effects that those things have on your body. I think also just talking to them, particularly about the long term risks to the child's health. And parents are really tend to be sensitive about knowing that another exacerbation might be right around the corner, right on the heels of when they were hospitalized or had to lose several days of school is a good time to really embed that risk in their minds as they're thinking about what next to do for for their child. So for patients who remain uncontrolled despite initial assessment, when should referral to a specialist be considered?
So I really do encourage folks to take full advantage of asthma specialists for children. I think the bar can be really quite low. I think children who require more than low-dose inhaled corticosteroids and who still have not achieved full asthma control should have an asthma subspecialist weigh in on their care. I think children who have experienced two or more courses of systemic steroids are absolutely candidates for subspecialty assessment, especially now that we have more advanced therapeutics like biologics that have really been demonstrated to be safe and effective in children, that allow them to have substantial reductions in their exposure to systemic steroids, reductions in exacerbations, and even improvement in lung function. So, specialist referral opens up these possibilities to the right subset of patients. And it's part of that assessment. Uh, we perform what we now call asthma phenotyping, trying to understand the underlying biology of what's driving a patient's disease, because now our most advanced treatments are actually highly specific for individual asthma phenotypes that allow us then to target therapy to the appropriate disease pathways that are most active in an individual.
And when you're speaking to your referring general pediatrician, are there steps that the primary care provider can take before the referral that might help streamline the process or expedite some of the care that you're going to be offering?
I I think it's not a bad idea if primary care is able to get a CBC with differential that will provide the subspecialist with a blood eosinophil count, which is often very helpful in assessing a patient's appropriateness for a biologic. But my view is that once it's clear that a patient needs subspecialty care, I would just get that referral going as quickly as possible. Um, there's another exacerbation just around the corner for many of these children, and waiting for that is, I think, to the child's detriment. I think we really encourage prompt and early referral whenever possible.
So let's pause for a moment, and I want you, the audience, to consider this. Should success in pediatric asthma be defined by fewer symptoms or fewer steroids and fewer flares? So, Len, you talked about advanced therapies and biologics, and I'd like to dig in a little bit deeper on those. What do we know about these therapies in the pediatric population?
So the care of children with asthma and for that part, adolescents and adults has really advanced by leaps and bounds in the last 5 to 10 years with the approval of now 7 total biologics um, for asthma across the age range. We have biologics approved for children as young as 6 years of age with asthma. There are actually 4 that are approved in this age group: benralizumab, dupilumab, mepolizumab, and omalizumab. There are 2 more that are approved for patients 12 and above: depemokimab and tezepelumab. So we really now have great options. The evidence that supports these is that they reduce the rate of asthma exacerbations by as much as 60% compared to placebo when added on to usual asthma care with an inhaled corticosteroid based therapy. They've all been demonstrated to have very favorable safety profiles as well. Some of them improve lung function as well as a reduction in exacerbations and improve day to day symptom burden. So, your question earlier about what's really more important, day to day symptoms or exacerbations, to me, they're equally important because some patients have one mode that dominates their disease, and some have the other, and some have both. So I think both of them should be indicators and targets of our therapy. We've seen that at least a couple of these agents are capable of improving lung function as well. And given that the lung function that you have at the end of childhood very strongly predicts your lung function throughout adult life, we want children to finish their pediatric and adolescent years with the highest levels of lung function possible.
Yeah, as a pulmonologist, that really resonates with me as well in thinking about long-term lung function growth. And there was a study out of the Severe Asthma Research Program that evaluated these lung function trajectories over time throughout adolescence. And one of the key parameters that seemed to, one of the highest risk factors was repeat exacerbations, and they were cumulative, really speaking to if we can decrease the number of exacerbations over time, that we may really have an impact on long-term lung function. So let's finish with a few um, final thoughts. We talked about the importance of preventing exacerbations and preventing systemic steroid courses. And I think, some of the key pieces here are really identifying that a single dose of systemic steroids for an asthma exacerbation is a signpost that asthma is not well controlled. And this is a great time to start intervening and really anchoring the parents, the family, and the child to an effective asthma prevention strategy, now knowing the long-term effects of both uncontrolled asthma as well as difficulty with long-term risks of systemic corticosteroids. What else do you think really needs to be highlighted around the exacerbation and steroid exposure issue in young children?
I think, as we've said, any steroid is, at least systemic steroid, is too much steroid. And now that we have highly effective approaches to reduce and minimize those exposures, we should be working very hard to implement those treatment plans for children to reduce these risks. The steroid exposure is really the silent threat to childhood and adult asthma. And it's one that I think really warrants our attention. I think we really need to take an approach very much like our infectious disease colleagues have done with antimicrobial stewardship and be stewards of systemic corticosteroids. Because with that approach, I think we will lead to better asthma care and healthier children transitioning into adulthood.
Len, thank you for this great discussion around systemic steroids and asthma exacerbations.
Thanks for having me, John. Really enjoyed the discussion.
And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.